I'm Linda Elsegood, founder of the LDN Research Trust. It has been my honour to interview LDN researchers, prescribers, pharmacists and patients from around the world for many conditions. Thank you for joining us. I'd like to introduce Dr. John Robinson from Scottsdale in Arizona in the US. Thank you for joining me, John.
Thank you so much for having me, Linda.
Could you tell us when you first heard about LDN?
I first heard about low-dose naltrexone probably about 5 years ago, in terms of just having different colleagues kind of mention it. Did a little bit of research on it, not too much at the time. But as I was working more and more, I focused on thyroid hormone replacement and many patients coming in and having Hashimoto's thyroid disease. I found that the strategies that I was using wasn't really working as well as I would like. So I started to kind of re-explore a couple of years ago that LDN that I had heard of a while before. And I'm so glad that I did, because as I looked into it again, I really think I found a gem for patients with, particularly, again, the patients I'm working with are people with thyroid disease, Hashimoto's, and Graves' disease. And we've had great results here at our clinic, the Hormone Zone, here in Scottsdale.
Mm-hmm. So I know there are so many of our members that have thyroid issues. Could you explain to me about the markers and, how you treat these patients with LDN? Because my understanding is that they have to be monitored to make sure that their thyroid levels don't go completely out of whack.
Yes, and I've seen, just as a quick side note to answer that, I know I've read some things where there's indication that once somebody gets on LDN, they might need their thyroid dose adjusted down, meaning as their thyroid begins to improve being on the LDN, they might not need as much thyroid hormone medication. And that's possible. I admit I haven't seen that. Most of the time, I have patients on very adequate amounts of thyroid hormone, more than what they would typically get by a conventional doctor or conventionally minded practitioner. So the doses I'm giving are normally really beneficial for most people, and I really appreciate it. With that said, back to your original question about the markers, we are watching those markers very closely, and that's really one of the big goals of therapy. I'm looking to see for the markers for Hashimoto's and Graves to go down, and I'm looking for the flares that can happen with Hashimoto's, particularly flares of moments where patients really feel bad, almost in this inexplicable way. And LDN is able to help with this. So with the markers, the key markers are anti-TPO, or anti-thyroid peroxidase, and another one called anti-PG, or anti-thyroglobulin. Now, thyroglobulin and peroxidase are two necessary elements within the thyroid to be able to help with thyroid hormone synthesis. But what happens in an autoimmune condition like Hashimoto's or in Graves' disease, the immune system starts to attack certain elements of the thyroid gland, including those two enzymes and that protein, and we can measure that in the blood. So if a patient of mine comes in to see me and they have suspected thyroid disease and they have elevated markers, then the first line of defense now, or the offense, is going to be low-dose naltrexone. Because what we've seen now is a decrease overall in the markers. I'm still waiting to get more data, and I'm looking forward to really collecting that data to kind of show that, because there's still with LDN this sort of massive resurgence, I think, in the past decade, that I still think there's more data to be had, and I think it's up to physicians to continue to offer that, even if anecdotally. So that's one of the goals here at my office here at the Hormone Zone, is to collect this data and start showing that, in fact, these biomarkers are changing and patients are improving in their health.
Mm-hmm. So when a patient comes to you and you start prescribing, what dose do you start them on normally?
Yeah, I think it's very important to start low. A couple reasons. you never know when someone might have a side effect, and there are some that are possible. And also just because in general it's always good to start low. You never know how uniquely someone's biology is going to react to a medication. So for us, I prescribe the LDN in 1.5 milligram capsules that are created by a compounding pharmacy. So we start with 1.5 milligrams, and we move up the dose to 3 milligrams the next week, and then the week after that, we normally make it to 4.5 milligrams, and then I stay there generally. It's really rare for what we have seen thus far to see any major side effects or even insignificant side effects, and they certainly can be vivid dreams. And I have seen that before. I've had some patients come back and say their dreams get kind of vivid, the standard kind of nausea thing. But those things seem to go away within about a week or so. So I haven't seen anything like that or nothing that would have to even necessarily lower the dose. But that is one of the options, just to adjust the dose. I have seen one individual, if I think about it, that what we did was instead of, because she was having vivid dreams, we just moved it to morning dosing. So I really think that it is better to give it at night, at least with what the evidence is showing now. It's probably better to have that temporary endorphin suppression and rebound that's occurring at night. But the one patient that I can think of that we do have her take it in the morning, she's doing well also. So that's basically how we do it.
Mm-hmm. So it seems a win-win situation for your patients, not having the side effects but having the good results. And
yes.
And how long would you say it takes roughly before they notice an improvement or you see an improvement in the patients?
Sure. Well, as far as noticing, the subjectivity from the patient can be relatively quick, within a couple of weeks. Now, most of the time when patients come in to see me and I'm putting them on the LDN, I'm also doing quite a bit of other things in terms of their nutrition, helping with certain diet triggers that could be exacerbating Hashimoto's, certainly other hormone replacement therapy options that we have. I focus on sex hormones like estrogen and testosterone. So a lot of these things are being done concomitantly. So sometimes it's almost impossible to precisely figure out what's happening. But on the people that I've already been treating for a long time, I already knew who they were, knew how they were responding to the generalized treatments that they're on, and then I added the LDN. That's a little bit easier for me to be able to observe because then we can see, well, this is the one thing that's been added. And of those patients, they're doing amazingly well. Several people are telling me that they just simply have a better sense of well-being, and I believe that is the endorphin release that is occurring in general with LDN. And so they're getting just this overall mental, emotional balance from being on the LDN. And then from there, yes, we are seeing the biomarkers like the anti-TPO and the anti-TG change. But I'll tell you, prior to this interview, I was thinking about you yesterday. I had a patient come in to see me who was on LDN, had been on the LDN for about 6 months, and she was doing relatively well, and her anti-TPO was down. And she came in to see me, and her anti-TPO marker had jumped up to over 4,000. And so to give you a perspective, in general, we want to see the anti-TPO less than 60.
Wow.
So to see a number, a couple hundred, 200, 300, 400, we're normally like, wow, that's, it's getting up there. I've definitely seen it, 1,000 or 2,000. Some labs actually only say greater than 3,000. They aren't even sensitive enough to measure a number over 3,000. Hers was like almost 4,500. So after some quick investigation, it was found that, of course, she really had a great holiday. Christmas and a Happy New Year for her in terms of eating things that she shouldn't have been eating, particularly gluten and bread, alcohol, things that she knew she'd already had some allergies to. So I bring this up to say that, one, LDN, like any treatment, is not always perfect in and of itself. It has to be used within the grand scheme of a comprehensive approach towards health. And that also to mention that Hashimoto's disease will often be triggered by a lot of gut dysbiosis or problems with allergens and things like that are in the diet, like gluten, and that's kind of for a lot of people at the top of the list. And that exacerbates the autoimmune condition, which of course exacerbates what's going on with perhaps the thyroid or what tissue might be the weak link. So in her case, it really went through the roof, and we kind of had a chuckle about that. So we will make sure she gets back off of gluten and then probably be able to retest. But back to her in general, she did say that she felt a definite, that was the key thing that she said, starting on the LDN and been on it for the past 6 months, that she felt a distinct difference in her overall well-being being on it.
Mm-hmm. And would you recommend a gluten-free diet for all your patients?
Well, and all is not normally the way I would look at something most of the time. I think that most people have some level of issue with gluten, but probably not everybody. So some people can maybe handle a little bit of gluten, or it might not necessarily be the issue for them. There might be some other allergens. But in general, I think that the type of wheat that we're exposed to in the West might not be the optimal species, and that form of gluten is causing issues with people, and that staying away from it in general is a good idea. But at the hormone zone, one of the ways that we help to treat autoimmune conditions is also focusing on the ketogenic diet. And the ketogenic diet is a diet that keeps carbohydrate low, in and around 5%. So inevitably, when you're keeping carbohydrate at that low level, you're going to be pretty much away from gluten anyway, just because breads and things like that tend to have a higher carbohydrate amount. So for those people that need something like that, that type of diet intervention, then the ketogenic diet is the way to go. So that's kind of helping with the gluten perspective there.
Mm-hmm. And you were saying that it's mainly patients with thyroid problems that you deal with. And how do people get hold of you to get an appointment to see you?
So the name of my website is hormonezone.com. That's hormone-zone.com. The practice phone number is 480-338-8070, and we are conveniently located right in Scottsdale, Arizona, very close to the Scottsdale Airport, not far at all from the Phoenix Airport.
And I'd also like to add that you were telling me that if people did an initial consultation with you face-to-face, you would be able to follow up with a telephone consultation. Correct.
Yes, I just need to see someone physically in the office initially, and once we've established examination and diagnosis, we can then move forward with the appropriate treatment, and if that includes LDN, I would be more than happy to prescribe that very effective and inexpensive medication.
Thank you very much for sharing your experience with us.
Thank you so much for having me. I've been very excited about what the LDN Research Trust has to offer, and I think it's excellent. And I think the work that you're doing, Linda, is also excellent, and more power to you out there with this.
Thank you.
Thank you.
Do you have LDN experience to share? If so, please email me, linda@ldnrt.org. I look forward to hearing from you.